Today we will see, this afternoon actually, we will see 3 urologists that the basic requirement was publishing 2 papers. That happened with these 3 fellows, of course, as you already see on this slide, and then we are already very, very proud of them. But of course, I mean, we need the committee, I mean, to judge on this, whether this is true, whether this is really their work, whether they really can think scientifically, and whether they really develop to the level of PhD level. And we believe that is happening, but this is why we have actually an independent committee. So our committees, I mean, actually professors from our partner universities, Professor Mátyás Benó, Csaba Bérci, István Király, Dániel Bányai, I'm reading so I don't make a mistake, Mirkos Damási, Zsolt Molnár is different because he's from Semmelweis, but still, and not a urologist, but he's a prominent scientist and also actually a very important player in translational medicine, I mean in our center. And then we have Kanem Fazekas, who is our biostatistician expert, and also Krisztina Csőke-Kabai, who is the SMS who takes care about all the details. But if anything goes wrong, that's my fault, not your fault, so don't worry. Okay, so with this word that I would just pass the chair to Professor Király.
Dear committee members, dear audience, let me introduce my PhD student, Anett Szabó, who was born in 1995 in Budapest and raised in Helsinki, Moscow, Cyprus, and Budapest. She completed her secondary education in Nicosia, Cyprus, and during this period she volunteered at the Nicosia dog shelter for several years, then for half a year at a local veterinary practice as an assistant, and spent 1 week volunteering at the Committee of Missing Persons for the Anthropological Laboratory in 2013. Anett began her medical studies at the Faculty of General Medicine of Semmelweis University in 2014. As a student, she joined the Scientific Students Association under the supervision of Nicolette Szűcs at the 2nd Department of Internal Medicine, working on the topic of transsexualism for 2017 to 2021. She also took part in a research on disorders of sexual differentiation at the 1st Department of Pediatrics in 2019 and 20, and on the adult growth hormone deficiency at the 2nd Department of Internal Medicine. During this time, she won first prize in the endocrinological section of the Student Scientific Conference in 2019 for her presentation on transsexualism, and later participated in the National Student Research Conference with the same topic. In 2019, she attended the CIRS conference in Barcelona, and in 2021, she presented a poster at the conference of Hungarian Society for Endocrinology and Metabolism on growth hormone deficiency. In 2021, Anett started working as a resident doctor at the urology department of the Semmelweis University, and simultaneously she began her PhD studies under my supervision at the Károly Rácz Doctoral School of Clinical Medicine and the Doctoral School of Theoretical and Translational Medicine. From 2022 and 2024, she also worked as a scientific methodology supervisor at the Center for Translational Medicine, where she provided methodological support for research projects. Since 2022, Anett has been an active participant in both poster and oral sessions at numerous national and international andrology and urology conferences, including the Congress of the Hungarian Society for Andrology, Urology Days of the Botanical Garden, Congress of the Hungarian Society of Urology, and the Semmelweis Symposium. In 2022, she presented Translational Medicine in Andrology at both the Central European Meeting of the European Association of Urology and the European Congress of Andrology. In 2023, she received the 2nd prize for Best Poster Presentation at the Central European Meeting for her work on non-obstructive azoospermia, and the 3rd prize in the CAM country competition for her presentation on sperm DNA fragmentation. In 2025, Anett participated in the joint meeting of the American Society of Andrology and the International Congress of Andrology as a co-chair of the poster flash talks, as a presenter of a selected oral presentation titled Prediction of Sperm Retrieval in Non-Obstructive Azoospermia using Share-Wave Elastography and Artificial Intelligence-Based Software. And as a representative of the Hungarian Society of Andrology, she presented the 2030 bid for the European Congress of Andrology. She has attended the educational courses of the European Academy of Andrology annually since 2022 and completed the European Academy of Andrology Budapest School in Microsurgery in 2023. Anett is an extremely diligent and hardworking young scientist. In her free time, she enjoys traveling and sports, especially horse riding and Zumba. She is a caring owner of a Hungarian Vizsla and has been active in animal protection. I'm confident that Anett has made remarkable progress during her PhD studies, and today we have reached the culmination of her hard work, and it is the time for her to present the results of the research to you. Thank you so much.
Thank you very much for the kind introduction. Dear chairs, dear members, dear guests, let me present you my topic on male infertility, the functional side of the spermatozoa. My name is Anett Szabó. I work at the Department of Urology under the supervision of Zsolt Kopa. And I'm working with my SMS, the Scientific Methodology Supervisor, Szilárd Váncsa. My vision was to educate patients regarding our findings on male infertility, and my mission would be a larger scale education of the population. Throughout these 4 years, I had 5 major topics. I will present 2 of them in detail, which are the basis of my thesis, and I'll say a few words at the end about the last 3. So a few words about infertility. Infertility rate in developed countries is quite high, and in Hungary, it is estimated to reach even 20%. Sperm DNA fragmentation is an evidence-based test which has been included in the guidelines recently, and I will talk about this in more detail. We wanted to look at risk factors which affect male fertility, so for this reason we investigated lifestyle factors, diet, obesity, smoking, and many others, and later on the interventions which could ameliorate it. So my first project was about the risk factors associated with sperm DNA fragmentation. So about sperm DNA fragmentation, it is the only evidence-based functional test that we can perform to assess male infertility, but we have no exact cutoff values and no normal range. What we usually say is that it is considered to be optimal below 25%. We can expect adverse pregnancy outcomes between 20 and 30%, but patients are still eligible for in vitro fertilization treatments under 50% of DNA fragmentation. One of the reasons why there is no normal range is that there are several different assays which can be used to assess sperm DNA fragmentation. One of them, well, these are the 4 major ones that can be used. The sperm chromatin structure assay, the STD, tunnel, and comet assay. So for our first project, our hypothesis was that there's a correlation between the studied risk factors and sperm DNA fragmentation. For this reason, we evaluated males. We looked at a certain risk factor and compared it to the absence of the risk factor. And the outcome in every case was sperm DNA fragmentation. Our aim was to investigate the effect and the extent of suspected and known risk factors on sperm DNA fragmentation. We conducted a systematic search in 3 medical databases, and we began with almost 27,000 articles. And after a thorough selection, we extracted data from over 200 articles. So So we group the risk factors into the following categories. This is the first one, the associated health condition. You can see on this graph that these are the risk factors, the main risk factors that we evaluated. You can see that we compared the risk factor to the absence of the risk factor, and then calculated the difference in mean sperm DNA fragmentation. So the risk factor which had the highest effect on sperm DNA fragmentation was diabetes, which increases sperm DNA fragmentation by almost 14%. The next one was the presence of varicocele, which has similar effects. And as we go down, you'll see that there are some infections, some malignancies, which have lower, lower effect on DNA fragmentation. So the next group was lifestyle factors. Here, the major one that we found to have the most detrimental effect was the effect of heavy smoking compared to non-smoking, which again had almost a 10% difference in sperm DNA fragmentation. And as we go down, you'll see that we evaluated the effect of BMI, the effect of drinking, and the effect of sexual abstinence times. The third group was the other factors, which we could not group into the previous ones. Here, what I would highlight is that we have age in this other factors group. We have pesticides, insecticides, pollution in general, and reactive oxygen species. I would highlight from this diagram that you can see the different age categories, and the most dramatic change in sperm DNA fragmentation occurs at the age of 50. So there is a more drastic increase after 50 years of age, which is over 10% again. So as a conclusion, we can say that varicocele, abnormal glucose tolerance, smoking, and increased age certainly increased sperm DNA fragmentation. And we could also observe a dose dependency when we looked at the amount of cigarettes smoked. As a summary, our main strength was that we looked at all the risk factors that have been studied up to that point. We included a very high number of articles and, of course, a very high number of patients. But the limitations include the lack of longitudinal studies, the fact that we cannot exclude the effect of other risk factors. We can't only look at the single risk factors that we are currently studying. For certain risk factors, we had a low number of studies, and pretty much in every case, we had a very high heterogeneity. As an implication for practice, based on our findings, we can give specific suggestions to patients on what they should be careful about, what risk factors to avoid, if possible. And as an implication for research, we can say that obviously more studies are needed, especially for those risk factors where the heterogeneity was high, and the best solution would be the establishment of registries. Our second project is the continuation of the first one, where we were looking at the interventions which could potentially improve sperm DNA fragmentation. Our hypothesis was that by targeting risk factors with specific interventions, we can decrease sperm DNA fragmentation. We looked at any intervention that we could find, and we wanted to see if that intervention had any effect on sperm DNA fragmentation. So for this reason, we investigated males, and an intervention could have been lifestyle changes, medications, or surgery, and compared it to the absence of lifestyle changes, no medication, no surgery, or a placebo, and the outcome in every case, again, was sperm DNA fragmentation. The aim was to investigate the interventions that could potentially decrease sperm DNA fragmentation, and therefore guide both clinicians and patients towards what would improve their fertility the most. So we again conducted the systematic search in 3 medical databases, PubMed, Embase, and Cochrane. We had almost 37,000 articles at this time and extracted data from 86 at the end. And here are the main results. One of the major interventions that we were looking at is the varicocelectomy. What is shown on this graph is that we evaluated the effect of varicocelectomy at 3, 4, 6, and 12 months. We were comparing the sperm DNA fragmentation data of the patient before the surgery and at these time points. With the different colors, we were showing the different subgroups based on the assays that were used in each study. And what you can see here is that that performing varicocelectomy does improve sperm DNA fragmentation, depending on which part of the graph you're looking at. It's approximately 10%, but the greatest increase is seen after 6 months. The next intervention that we were looking at is the use of antioxidants. Again, we performed subgroups here. But this time based on the type of antioxidants the patients were given. In the middle, you can see that patients who were evaluated here were given a monotherapy, regardless of the antioxidant type. Only a single type of antioxidant was given to the patient. Then on the right, you can see a combined treatment, so any antioxidant given in a combination with another antioxidant, or even more antioxidants. And in the beginning, the left side of the graph shows the combination of these two, so either monotherapy or combined. Here we were looking at this data. This graph is showing the data after 3 months, but we have the data for 6, 12, and so on. But here what you can see is that regardless of what kind of antioxidant treatment you use, whether it's a monotherapy, a combined therapy, and pretty much regardless of what kind of sperm DNA fragmentation assay you're using, there isn't much of a change in sperm DNA fragmentation. The next treatment that we evaluated was the follicle-stimulating hormone. Here on this graph, you can see the data after its use for 3 months. And we can see that the mean difference compared to their pre-treatment data is approximately 7%. So this one seems to be a bit more effective than antioxidants. What I would highlight here is that FSH in these studies was not given to hypogonadal men, but to any patient who had infertility. Then the next large group was lifestyle interventions. Here I would like to highlight that, again, what you can see is that there is a very small change in DNA fragmentation. These studies evaluated lifestyle changes for 3 months, but the data were very heterogeneous because they were looking at exercise-based lifestyle interventions. They were looking, in other cases, they were looking at dietary changes, and yet again, in other cases, they had the two combined. So based on this, this is the most heterogeneous group that we have. So I would not necessarily say that that lifestyle changes do not affect sperm DNA fragmentation, but this is not the graph I would make conclusions from. So what I would say is that varicocelectomy undoubtedly improves sperm DNA fragmentation if the indication for surgery is correct. But about the other 3 interventions, lifestyle, antioxidants, and FSH treatment, the results are not so convincing, but if we would have to choose one, then FSH seems to be the most promising of these 3. As a summary, again, we had included every intervention that we could find in the literature. We had a very high number of articles, we had a very high number of patients. We again did subgroups as for the risk factors as well. But again, the limitations include that we could not eliminate confounding factors. We had only very few RCTs to include. We had non-uniform interventions in most of the cases, and thus we had a very high heterogeneity for most interventions. For implications for practice, I'd like to highlight that patients should be encouraged to contribute to their own well-being. What we can help them with is to perform a varicocelectomy with the right indication criteria. Maybe in the future we'll try giving FSH more too, but for now antioxidants are the ones that do not seem as promising as how popular they are currently. And as an implication for research, it would be very important to standardize the DNA fragmentation assays, both for this topic and for the previous one. And both for this one and the previous one, it would be very important to be able to assess reductive and oxidative stress correctly, because that's how we would be able to say whether antioxidants should be given or not. I have some additional projects. Two of my projects about non-obstructive azoospermia. Azoospermia is the lack of sperm in the ejaculate, and there are two subgroups, the non-obstructive and the obstructive. The obstructive is the luckier case, where you can eliminate the obstruction, and then you will have sperm in the ejaculate. But with the non-obstructive, there is a malfunction of the sperm production. So you're not as lucky to, it's not such a straightforward procedure, and it's not always feasible to get sperm even from the testicles directly. And you do not know it in advance whether you'd be successful once performing the surgery or not. So for this reason, we developed an AI-based model to predict the success of sperm retrieval, and currently this work is at Scientific Reports. We got back a major revision, which is due tomorrow. We also established a registry for the same purpose. We are evaluating these patients and prospectively collecting data in more detail. And my last major topic was the non-palpable testicular tumors, where we're gathering these patients' data. What you need to know about it is that in non-palpable cases, testicular tumors are mainly benign. Thus, removing the entire testicle is an overtreatment, and we want to highlight this with our work that the testis-sparing surgery is a better approach. Some of my other activities include being a scientific methodology supervisor. As an SMS, I've already had 11 articles as a co-author, and I also had 2 articles not related to being an SMS in the field of andrology, and also we had a book chapter accepted recently. I'm a member of the Andrology Journals Publication Committee, and a member of the upcoming European Congress of Andrologists Program Organizing Committee. And at the end, I would like to thank my supervisor, our department, my colleagues for all their help. I would like to thank my family and for your attention.
Thank you for your presentation. I would like to ask your opponents to take their questions. First, Dr. Bányai.
Thank you. Congratulations.
Thank you.
It's an amazing work. Amazing data mass, what you were progressing. And it was a clear presentation. So I had, the first question is connecting your 2 topics. Is there no contribution? So in the first topic, you thought that after 5 days of abstinence, the DNA fragmentation is rising already after 5 days. And in the second, we saw that after, for example, FSH therapy or antioxidant therapy or varicocele, we could see the change after 3 to 12 months. Is there no contribution between these two things?
Well, regarding the abstinence times, I think it's best if I go back to show you the different data, how we divide it into subgroups. So basically, what we are currently advising patients based on the guidelines is either 3 to 5 days of abstinence or 2 to 7 days of abstinence. Here, what we wanted to see is that there is a theory that ejaculating more often helps decreasing your sperm DNA fragmentation. But based on these results, we did not really see this trend. What we did see, though, is that in some studies, we had patients with spinal cord injuries, and those patients who had abstinences for not days, not weeks, not months, but rather years, in those cases, the sperm DNA fragmentation is very high. It's usually above 50%.
Thank you. And the second would be in the clinical decision making, if this DNA fragmentation is one parameter, yes. What would you consider more critical, this or the number of the sperm number?
Well, it has to be evaluated together. Both of them are important. We were only looking at sperm DNA fragmentation in my topics because it hasn't been studied so well. I was very lucky that it was included in the guidelines the year I started my PhD. So we have data for the rest, for the classical parameters, and that's what we start with, the classical parameters. But in cases where, for example, there are recurrent miscarriages or an IVF treatment is necessary, we always advise the patients to check their sperm DNA fragmentation.
Thank you.
First of all, congratulations. It's a really valuable contribution to the understanding of the factors affecting the DNA fragmentation. First of all, I would like to emphasize, but you also emphasized that in spite of the fact that lifestyle factors had less effect on the DNA fragmentation, it's still really important to consult the patients to improve their lifestyle habits in order to improve their fertility status. First of all, my question is, you may have also mentioned in the future study recommendations about the standardization of the different DNA fragmentation methods. Is there an assay which is maybe better than the others, or what is your recommendation? Which test would you prefer?
We only have we only have access to the SCSA. I don't know about the other clinics. Probably you have access to only one, too. Some of these assays are quite expensive, so even in studies which were focusing on which assay to use, even in those, I don't remember a single study where all four major assays were compared. So each one has its benefit. One of the benefits is that obviously some of them can look at single strand breaks, others can look at both single and double strand breaks. For example, we use SCSA because it can be well standardized. Of course, you have to evaluate the cost. Then, for example, the helosperm test, it's very dependent on the observer. So these are all factors that need to be considered. So I would not necessarily recommend a single best assay, but probably the best solution would be to have two assays that we can use regularly and compare those values and consult with the patient on how each is different. Like, for example, one can tell you the single strand breaks, the other one the double strand breaks as well, which is important for IVF.
Thank you very much. Yes, this is an important information. You have mentioned that you have seen some improvement after FSH therapy. Yes. Could you define the candidates who can be candidates for FSH therapy?
Well, this is what I was surprised by, that they gave FSH to any male who was infertile. They did not have to be hypogonadal. These were studies mainly from Italy, where FSH is more available. So they tried giving it to everyone, and they did see an improvement in many cases.
And did you see any subgroup analyses which can be benefit, or what was the length of the FSH therapy they recommended?
We have subgroups for 3 and 6 months, and we have different dosages, but I presented this one because it represents basically all the studies.
Thank you. And my last question is, if there is a patient who has constantly and consequently higher DNA fragmentation, but is still below 50%, and you have to still proceed with the IVF cycle, how can we improve the outcome of the IVF cycle in those cases, in those patients?
Well, these are the interventions that we could find data for. So if the patient has a varicocele, and we have excluded every other risk factor which could deteriorate their sperm, then we can of course do a varicocelectomy. And as I showed you before, it's best to use the sperm after 6 months. Lifestyle factors, that's the easiest to advise, but here we only had data for exercise and diet, and I think that's because we, as we were getting back the review from the journal that we submitted it to, one of their comments was that we did not include the cessation of cigarette smoking. But there are no studies how can you collect so many people who would willingly quit smoking for such a long period of time, for at least 3 or 6 months, and group it all together? I don't think you can easily find that many people.
And in case of idiopathic cases, when there is no varicocelectomy, no smoking, is there any selection options for the?
Well, these are the cases to whom we say that there's the option of antioxidants. They can try it. It's not guaranteed that there will be an improvement, but we can see and check their DNA fragmentation again periodically. So even if there is an improvement at the beginning, if they keep taking antioxidants, then DNA fragmentation might worsen again after a time. So it's important to tell them that we cannot evaluate the reductive and oxidative stress within the body, and thus we cannot say whether antioxidants will be beneficial for the patient. But if there are no other options, other potential interventions, this is something that's worth trying.
And as my very last question, what are your opinion about the sperm selection methods?
We did not evaluate that.
In general, are there any future in those sperm selection methods for IVF cycles?
Well, regarding sperm DNA fragmentation, the problem is that once you check the DNA fragmentation, you cannot use that sperm anymore. But it would be nice if you could develop a method where you could check the DNA fragmentation without destroying it.
Okay, thank you.
Congratulations.
Thank you.
I also would like to ask about FSH treatment. This treatment in male infertility has changed a few years ago, and now we can prescribe FSH on a lower third of the normal range of the FSH. Previous time only if it's hypogonadal patient and low FSH level. But what do you read in this article from the Italian colleagues that did they use FSH treatment for normal FSH or higher FSH level? And what do you think DNA fragmentation may be the indication alone for FSH treatment? For example, high FSH or not on the future, because we can see that in these cases when the FSH is high, we cannot find any changing from the classical parameters. So this is my question.
I'll tell you now that not all articles are of very high quality that we included. So not every article assessed preoperatively FSH, or at least they did not report it. What they usually said as part of their inclusion criteria is that they gave FSH to any infertile male. Those that did say that those that did say something about their pre-treatment FSH levels, those were normal, but we don't know in every single case. But even pooling the results, we see a relatively large improvement in DNA fragmentation. We can't again say that it's... In our articles, we use the threshold of 10% to say whether it's a clinically relevant change or not. And 7% is quite close to that.
Okay, and one more question about the spermatogram and functional tests. How importance of these basic investigations change nowadays? And could you tell me or help us to put on the right cells to the functional test, which can we use nowadays, and any future options?
When to use the sperm functional tests?
Yes.
Well, the first steps are always to check the standard parameters, and if there is any abnormality, we check it again. And afterwards, we go on to the sperm functional test, the sperm DNA fragmentation test. It has to be paid by the patient previously, but now it's included in the package. So the cases when we usually advise them to do this, sometimes they do it by themselves once they read a bit about it on the internet, is that when there's been a miscarriage, and if they're planning on undergoing IVF treatments, or if they're undergoing, it happens unfortunately quite often that they are already undergoing IVF treatments and it has not been checked. So even during an IVF treatment, it's worth checking it.
Okay, thank you.
Congratulations.
Thank you.
I have just a simple question about the HPV, right? Does the vaccine, the HPV vaccine, has any effect on the sperm DNA fragmentation? What do you think?
Unfortunately, we did not have data for this, not even a single article on HPV vaccination, but from the risk factors, HPV did not really affect sperm DNA fragmentation. So I think the vaccine is to be given to patients, but not for this reason.
Right. In your general practice, would you recommend the patient to get the HPV vaccine? Would you?
Yes.
Okay, thank you.
May I, as a red herring, have a comment and a question? Although I'm an intensivist, I really enjoyed your presentation.
Thank you.
And just, I was very happy that you found that antioxidants don't seem to make any sense. Because I mean, antioxidants are extremely popular. They have an excellent PR these days, but there is a serious misconception regarding antioxidants, because the more you eat, the more you excrete. It is a very, very fine-tuned balance in our body, like acid and base, like pro and anticoagulation, and oxidants, antioxidants. And so I'm just curious, how do they recommend to use it? How do they know how much to give, when to give it? Now, forget about the rationale, which is total nonsense in my opinion. So what is your take on that?
Well, we don't generally recommend it. It's like the very, very last resort if we run out of every other potential intervention that we could think of. Usually, when they come to us, they are already taking antioxidants. We had a list. I think the most antioxidants the patient was taking was around 20. And what we have observed.
And what is it? Red wine from Sexard, or what kind of antioxidant? Because that makes sense, yes, to be honest. That's the only one I could recommend.
No,
vitamin C or what?
Our patients don't usually drink. At least that's what they say.
And they are ill. Yeah, I know.
Yes. So they are usually vitamins, zinc, micronutrients. Yes, selenium as well. So when they come to us, they're usually already taking many, many antioxidants. And what we usually hear from them is that their wife prepares the antioxidants for them. And if the DNA fragmentation or any other parameter worsens over time, then the wife tells them that they probably weren't taking their antioxidants properly, so they get an even higher dose.
I know that there are some studies that the sperm count in males are decreasing, like since I don't know how many years. And you mentioned that you don't have like normal range for your outcome.
Yes.
But do we have information whether it's also going in the wrong direction?
Not really, because it's not a very recent test, but it has been included recently in the guidelines. And since there are so many different methods, it's quite hard to evaluate whether they were measuring the DNA fragmentation the same way. We even had articles in which they did not even specify the type of assay used. They only said that they measured sperm DNA fragmentation. So these are not the articles based on which you would draw any conclusions.
Yeah, because I would be like worried if you have like not that recent articles, that these are not comparable, right? Because if you include older articles, then the sperm count and other factors could be very different than the recent articles.
We did subgroups based, wherever they reported the type of assay they used, we did subgroups based on that.
Thank you.
Thank you.
Dear candidate, dear colleagues, dear guests, it's great pleasure for me to congratulate to you based on the decision of our committee with 93%. You will get the degree of Doctor of Philosophy.